Hello, everybody. So it's day 17 in quarantine for me. I don't know, but I'm so excited that you're all here. Um, I just wish we're under better circumstances. But we're going to answer all of your questions today about what you should do. What are your responsibilities when it comes to being exposed to COVID-19? And we have our presenter back, Dr. Scott Munsterman. So, if this is your first webinar with Dr. Scott, he's the founder and CEO of Best Practices Academy. He is a graduate of the University or Northwestern Health Sciences University. I was going to say that all wrong. He also serves as vice chair of the board of trustees and is on the president's cabinet as chief care of delivery. He's kind of the man when it comes to digging into all of this stuff. He's been working around the clock to just make sure that you guys have everything you need to know. Just be aware that this stuff is being updated all the time, and we're trying to keep you updated as quickly as possible. So, without further ado, let's get started.
My name is Dr. Scott Munsterman, here to visit about a very important topic throughout this whole public health crisis, and that is exposure to COVID-19 in the practice. What should we do? As things have transpired over the last few weeks, we have noticed more and more practices, chiropractic colleagues have been encountering exposure of COVID into their practices, and it's very important that we touch on this topic as to what we need to be doing about that. And what does the CDC provide us in terms of guidance in that area? Well, that's what we want to talk about. But first of all, a special thanks to ChiroArmor, ChiroHealthUSA, and Best Practices Academy. They've done a great job at pulling this together, trying to digest all the information that's out there, and to be able to provide it to you, hopefully in a manner that would be a starting point for you. And when I say that, it's important to understand that what we're doing here is making a good faith effort to try to surmise the information, draw conclusions and summaries the best that we can at this particular point in time with the information that's available from the CDC, and present it in a manner that will hopefully give you a head start and a running start as to you getting your research done on the matter. And so everything that we're doing here and that we're bringing to you, it certainly does not remove any responsibility on your part to educate yourself and your staff, have that direct knowledge and communication with not only the CDC, but your local and state public health authorities. And so there's no legal advice provided here, and we definitely encourage you to refer any questions to your healthcare attorney, malpractice carrier, or public health authorities, as we've talked about. So let's do a bit of a deep dive into the exposure question, exposure to COVID-19 in the practice. It's here, but how should we respond? And of course, we've talked a bit about this already. What is the strategic response that a practice should have moving into this whole crisis, this public health crisis? Well, we talked about a clinic facility response in the past, a patient care response, and a public health response. And we're going to touch on all three of these key areas as it relates to understanding how do we respond to COVID-19 being in our practices. And so first and foremost, as we've talked about, creating that clean and maintaining a safe, clean clinical environment. And so we draw recommendations from the CDC, and we will be referencing all throughout this module links in these particular topical areas. And of course, this one is very important because the CDC provides recommendations for patients with, in regards to patients with suspected or confirmed COVID-19. And of course, you can access that link right there, and it's all about minimizing the chance for exposures. It's ensuring facility policies and practice are in place to minimize those exposures, as we've talked about, keeping a good, safe, clean clinical environment, implementing screening before patients arrive, and when they arrive, implementing screening again, and then throughout the patient's visit, making sure that staff has personal protective equipment and that you're utilizing that, and that when the patient leaves, that the patient's room is clean and disinfected. And of course, it's It's particularly important to protect individuals that are at increased risk for those adverse outcomes of COVID-19, and we've talked about them in the past, older individuals and those with comorbidities. But we also need to include in that category as well would be healthcare personnel who are in a recognized risk category. And that's what we're going to be talking a bit about towards the mid to end of this module, is categorizing us as doctors and our staff in risk categories and understanding what we need to do based upon that categorization of what's going on within our practices. And of course, ways that we've been trained now and have talked about in previous modules are notices, those visual alerts, those signs, those posters at the entrance or in strategic places. That's very important. Helping patients know what the instructions are and on how to cough and sneeze and to take care of that and cover themselves. And then we've recommended as well that doctors consider triage stations located either outside the facility or in certain areas to be able to screen their patients before they enter. And it's all about the standard and transmission-based precautions that we've talked about in the past that lend to us having a good, safe, and maintain a safe clinical environment and create one. And standard precautions, the CDC calls it, of course OSHA calls it universal precautions, but what standard precautions does is it assumes that every person is potentially infected or colonized with a pathogen that could be transmitted in the healthcare setting. And so essentially it's everybody that walks through that door, whether they've screened negative or not, we in our minds have to think, okay, this person could be infected. There could be a pathogen that could be transmitted, and we just have to be very careful and be on our game. And that's how CDC wants us to look at it. That's how OSHA wants us to look at it as well. And so there's key elements within the practice that we're going to cover again that we need to be employing. So first of all is hand hygiene. Performing hand hygiene before and after patient contact. And if we use gloves, that we make sure when we take gloves off that we also wash our hands, that we use alcohol-based hand rubs with 60 to 95% alcohol, or washing our hands with soap and water for at least 20 seconds. And of course the CDC has put out there that hand washing and brisk rubbing of our hands within that 20-second time period is the best. And then we want to make sure that our hand hygiene supplies are in order and that we have those supplies present. Use of personal protective equipment, and of course this is a link to the OSHA standard regarding PPE, and it's in, and they state the importance of staff and doctors receiving training and being able to demonstrate an understanding of when to use PPE, what PPE is necessary, how to properly put it on, take it off, preventing self-contamination, how to properly dispose of or disinfect and maintain PPE, and of course the limitations of personal protective equipment. And so that's a big part of it. And of course the face masks, if they're worn properly, they can block respiratory secretions produced by the wearer, that individual that's actually wearing it. It prevents them from putting forward those respiratory secretions that could be contaminated, and that's called source control. And of course face masks have been cleared by the FDA as used as medical devices, and they should be used once and thrown away in the trash. Another element of being able to cut back on the transmission would be a no visitor policy. Unless that patient needs physical assistance, no visitors should be allowed to enter the clinic facility to reduce that unnecessary risk of exposure. And of course, implementing good sound infection control also consists of making sure that we have our equipment cleaned and disinfected, tables cleaned and disinfected, that we utilize EPA registered disinfectants under the list N, and then how we manage our laundry and regulated waste, as we've talked about in previous modules, is important. Of course, handling of laundry, whoever's in charge of cleaning that, the least amount of agitation. If you do suspect that there is some infectious material on the particular material, that it's placed in a red bag so that the individual that does do that cleaning understands that there could be infectious material and uses personal protective equipment when they do the laundry for that material. And then, of course, the regulated waste side of it, and how you dispose of personal protective equipment, that should also go in a red bag, which signifies that it is regulated waste. And so those are OSHA requirements to make sure that you do follow. And if you don't have a red bag, to make sure you have a biohazard label that would go on it. Now, this is the link that will bring you right to List N, which includes the products that meet EPA's criteria for use against the virus that causes COVID-19. And then, of course, another way that we can help this whole process is providing our patients with the resources. There's a couple of links here that may be very helpful. This one's in regards to cleaning and disinfecting households. You can provide that to your patients, as well as this link, which talks about the precautions for household members and intimate partners and caregivers. If they have a family member that is symptomatic or has a confirmed COVID-19 disease, or it could be somebody who is under investigation, patient under investigation, and monitored by the public health authorities. In either case, these two particular items can provide your patients with some good information about how to keep their homes clean and safe. And of course, we want to limit how germs can enter the facility. So canceling anything that is not necessary, keeping our care, as we've talked about in the past, patient care to acute care only, is very important, and limiting the number of people that absolutely have to come into the clinic. And of course, encouraging the use of, again, of personal protective equipment. And then always have the idea of, okay, we need to isolate patients. We need to keep people apart. So setting up a separate, well-ventilated triage area to do your screenings would be good to do. We've had doctors that have had patients wait in the cars, and then they text them when it's time for them to come in for their appointment, and they keep patients coming in just one at a time. Of course, doctors rearranging the furniture in their reception area, taking chairs out and spacing them over 6 feet apart. All of these things are important control measures that we can use to try to isolate patients and keep everybody separate and keep that distancing as much as we possibly can. And then, of course, protecting our staff and doctors through training, emphasizing hand hygiene, installing barriers to limit contact with patients at triage, limit the number of staff providing care, implement PPE, of course, as we've talked about. And all of these and more questions can be answered with this link direct out of the CDC. But we've covered a big part of, again, in a high level, that clinic facility response. How do we go about creating and maintaining a good, clean clinical environment? The things that we need to do as healthcare personnel, as healthcare providers, in protecting ourselves, use of personal protective equipment, gloves, mask, that type of thing, keeping everything wiped down well with disinfectants, and then, of course, screening our patients and understanding that we want to do the best we can to isolating patients and keep, of course, keep open so that we can take care of those acute patients. That's very needed today, but at the same time, being careful about the distancing that we need to be. And of course, as we move into patient care response, into this whole idea, that implementing screening and clinical assessment measures are very important. As we know, clinical symptoms, identifying those and screening for those. We've covered that, what our clinical assessment should be, making sure that we take body temp on patients that do come into the office. And we recommend to complete the vitals with blood pressure, pulse, respiration, observation, and questioning their travel and community interaction that they have. We have created a resource page that many of you are probably now familiar with, and it's good to go there and be able to download tools that we provided that will hopefully give you a good start in some of these directions, as well as modules that will help you and your staff train better towards creating and maintaining a good clinical environment, as well as patient care. How do we triage patient care as we move ahead? Now, the last thing we want to talk about is really where we're going to camp the most in this module, and it is in regards to public health response. And of course, the question is, what is required of my practice when a patient has a positive screening or test for COVID-19? This is what we're running into now. A week or two ago, when doctors began screening, they were like, "Gee, nobody is screening positive at all, for COVID-19." But we noticed towards the end of last week, doctors started to say, "Hey, I had a patient come in and they weren't symptomatic. We screened them, but then they called me the next day or called me that night and they said they started having symptoms." And so it's like, what do I do? Well, what is required of the practice? Well, CDC does establish that very well. And the very first thing that's required of us is to be able to make a report to a public health authority. And so we need to have our policies in place within our practice that essentially says that if we do have a positive screening or somebody that we suspect could be COVID-19, could have symptoms COVID-19 related, that we communicate that to public health authorities. Uh, and we've got active links here that you can click on to locate your local public health authorities as well as your state health department. And of course, the pick in the upper right hand corner is the picture of the web page for the local, and you can click right into your state and get into your county on who you would report to. And then also on the lower left hand side of the screen, that state link will bring you into your Department of Health, and you can visit with. We would recommend that you visit with both public entities. Begin with your local, and then let it take you forward from there. They are in charge of tracking and actively monitoring what are called persons under investigation. Okay, PUI, and these are symptomatic people who meet CDC's definition, and they should be evaluated by a healthcare provider in conjunction with local health authorities. And of course, PUIs, uh, ones that are awaiting results for testing of COVID-19, should remain in isolation at home or in a healthcare facility until their test results are known. And of course, this link will bring you right to that area. You can learn more about it. But there is a handoff that happens when patients do screen positive, or when we do discover that hey, we did have somebody in that had symptoms with COVID-19, or a day or two later was found to be tested and have COVID-19. Well, our reporting responsibility is to our local and or state public health authorities, and then it's their job to take it from there. And so all the other reporting that needs all the reporting that needs to be done in this regard to at this particular point in time, based on the information we have from the CDC and that you can read all about in the links that we provided, state that we do that handoff to the public health authorities. So how should I respond? How should you respond if a patient's been determined to have COVID-19 and they've been in your practice? Well, the CDC has a statement about that, and they say that the contacts of asymptomatic people exposed to COVID-19, all right, if you're asymptomatic but you were exposed to COVID-19, that the CDC does not recommend testing yet, but they recommend symptom monitoring as well. And the asymptomatic people with potential exposures to COVID-19, that you are not considered exposed to it. And so if you're asymptomatic, then you are at a point where the CDC is not recommending testing, but it's important to monitor symptoms as time goes on. And so what we want to be able to do here is determine what the levels of risk for our staff and doctors are as COVID-19 spreads. And so the healthcare personnel with potential exposure to COVID-19, the CDC has delivered interim guidance in this particular area. And of course, the link is right there for your reading enjoyment. And healthcare personnel are defined as all paid and unpaid persons. It's good to define this to begin with. And it's all paid and unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. And so it's anybody that is in the practice, again, who is paid or unpaid, that is serving within that practice. And a key, as we mentioned just earlier here, is identifying early symptoms and prevent transmission. And so the signs and symptoms described in this particular guidance for healthcare personnel are more conservative than those described when assessing exposures for individuals not working in healthcare. Well, why would that be? Well, healthcare facilities should have a low threshold when you think about it for evaluating symptoms and testing symptomatic healthcare personnel, especially those healthcare personnel that fall into the high and medium risk categories, which we're going to talk about in just a bit. And of course, in defining exposure risk categories for healthcare facilities, as you work with your public health authorities, it's important to keep in mind that you'll be using your clinical judgment as well to assign risk and determine the need for work restrictions. And so one of those parameters that we need to consider is close contact. And of course, what does close contact mean? Well, it means being within approximately 6 feet of a person with COVID-19 for a prolonged period of time, such as caring for or visiting with the patient, sitting within 6 feet of the patient in a healthcare waiting area or room, having unprotected direct contact with infectious secretions or excretions of the patient, meaning that you're coughed on, and maybe you don't have a mask on, or that patient doesn't have a mask on, that would indicate that we would have close contact within that particular distance. Proper adherence to currently recommended infection control practices, including all recommended PPE, should protect the healthcare personnel having prolonged close contact with patients infected with COVID-19. That's a statement that the CDC has made, that if you are currently doing all the things that you should be doing in the practice, infection control practices, using personal protective equipment, that should be enough to take care of you and protect you from patients who are infected with COVID-19. Now, who would those people be that would have direct contact in a chiropractic clinic? Well, it would be the doctor or providers, chiropractic assistants, front desk staff, right? It'd be those folks that are within that 6 foot distance or less of that patient. Now, there's also what's called no direct contact, and that would be a healthcare personnel who may walk by a patient or have no direct contact with the patient, or their secretions or excretions and their no entry into the patient room are considered at all, and they would have no identifiable risk. Well, the healthcare personnel that may be one that would fit into that category with no identifiable risk could possibly be billing staff, and they can conduct a lot of their business over the phone. And so as you think about your healthcare workers that you have within your practice, think about it from the standpoint: who has direct contact, who does not have direct patient contact. The ones who have direct patient contact are the ones that immediately move into at least a low risk category. And you need to be thinking about, okay, what are those standard precautions that I need to follow? What personal protective equipment should be worn by the healthcare personnel providing care to asymptomatic patients that may have a history of exposure to COVID-19? All right, and that's really the patients that we're talking about here that we have come in the practice. We're treating our acute patients. They're coming in the door. They are, they don't have COVID symptoms, let's say, but they're asymptomatic, but they may have somebody in their household that is sick with COVID-19. So what do we do? Well, we just need to continue to follow those standard precautions as we talked about, regardless of suspected or confirmed COVID-19. If the patient is asymptomatic, then precautions specific to COVID-19 are not required. But until the patient is determined to be without such symptoms, you should wear all recommended PPE for the patient encounter. And so I guess what the CDC is trying to say here is that, it's better to be safe than sorry. Make sure that you do equip yourself, and that you've got personal protective equipment that you are using, because as the weeks unfold, this will be very common. People will know people that have COVID-19, and there will be patients that are going to come in, be evaluated by us for their neuromusculoskeletal conditions that are not infectious, that are asymptomatic, but they have a history of exposure, and we need to use all standard precautions as we've talked about. So, what personal protective equipment should be worn by personnel who clean and disinfect rooms of hospitalized patients? Now, we don't have hospitalized patients, but I brought this forward because it's important for us to understand that we need to use personal protective equipment when we're cleaning. So, if there's any chance that there may be something that'll splash in our face or uh, uh, certainly get on our hands, we'll want to make sure that we use gloves and throw a face mask on in the event that that is the case. And so when we clean and disinfect, we have to keep that in mind. The other thing we need to keep in mind is how long does an examination room need to be vacant before we occupy it with another patient. And of course, the CDC states that for a patient who is not coughing or sneezing, and occupied the room for a short period of time, a few minutes, any risk to the healthcare personnel and subsequent patients lightly dissipates over a matter of minutes. All right. And so, but for those patients who have been coughing or remain in the room longer period of time, and this is where you have to use your clinical judgment, the risk period is likely longer, and you'll need to use your clinical judgment as to how long that patient was in there, how active were they in their coughing, uh, so to speak, or sneezing, and then figure out how long you need to have that room uh, without anybody going into it before you're able to go in, clean it, and have patients come in. And so that's an important criteria or clinical judgment that you will be making as a clinician if and when you get into those situations. So now let's talk about risk exposure categories. Now what are we talking about here? We're talking about our healthcare personnel. It's our staff, our doctors. We're talking about the risk exposure categories that they are in. All right, that they are in. And so no identifiable risk, low, medium, and high risk exposure. And of course, no identifiable risk exposure category is when the healthcare personnel in this risk category does not require monitoring or restriction from work, and there's no identifiable risk. And of course, with no direct patient contact, we talked about this just briefly, and no entry into an active patient management area where there'd be routine safety precautions, they don't have risk to exposure to COVID. And so there's no identifiable risk. And of course, we talked about maybe the billing person within the practice, maybe fitting that description. It's essentially defined as brief interactions with patients with COVID-19 or prolonged close contact with patients who are wearing a face mask for source control while the healthcare personnel were wearing a face mask. This is under low risk exposure. Defined as low risk exposure. And so those brief interactions, let's break this down. If you have low risk exposure, when you have brief interactions or prolonged close contact, and this is with a patient with COVID-19. So these are your risk, and you know that this patient has COVID-19, you are in a low risk exposure category. All right. And if that patient is wearing a face mask and you're wearing a face mask, you are in the low risk exposure category. All right. And so it'd be brief interaction with them or prolonged close contact with them, but it's that patient wearing a face mask while you are wearing a face mask puts you in a low risk exposure category. All right. So now what does that mean? Well, healthcare personnel in low risk categories should perform self-monitoring with delegated supervision. All right. And that what we're recommending is that you implement this across your clinic with all your staff. And we're going to talk about this in just a bit. But self-monitoring with delegated supervision until 14 days after the last potential exposure. If you are asymptomatic, you're a healthcare personnel, and you're asymptomatic, you're in the low risk exposure category where you've treated a COVID-19 patient, they had a mask on, you had a mask on, you're asymptomatic, you're not restricted from working. all right? But you're under a self-monitoring with delegated supervision for 14 days after the last potential exposure. Okay, and what does that mean? Well, you're going to be checking your temperature twice a day, remaining alert for respiratory symptoms consistent with COVID-19, and just make sure that you are asymptomatic before reporting for work, before you leave home. If you do not have fever or respiratory symptoms, and then it's fine for you to report to work. But you're monitoring your temperature, your body temperature twice a day, and your symptoms. All right. If you've been in contact with a COVID-19 patient, you've treated a COVID-19 patient, that patient has had a face mask, you've had a face mask, and you're in a low risk exposure category. You're asymptomatic in this category, you're not restricted from work, but you will be doing self-monitoring with delegated supervision. All right. And so as you think about that in the event, so you're in this low risk exposure category, in the event you do have a body temp that goes up, you do begin to have respiratory symptoms, then you immediately self-isolate and you notify your local or state public health authority and go see a primary care provider in the event that you would begin to develop COVID-19 symptoms. And so here's a scenario to think about. Patients treated in the practice and later discovered to be infected with COVID-19. Okay, what does the CDC have to say about that? Well, what they say is that proper adherence to currently recommended infection control practices, including all recommended PPE, should protect the healthcare personnel having prolonged close contact with patients infected with COVID-19. And so they're saying that in the event that you had a patient come in, then they're later discovered to be infected with COVID-19, if you've been doing everything you should be doing, personal protective equipment, and keeping things clean, then you should be protected and you should not have to worry about that. However, to account for any inconsistencies in use or adherence that could result in unrecognized exposures, healthcare personnel should still perform self-monitoring with delegated supervision. So even in this scenario where you treated somebody and later they were discovered to be infected, the question is, were they infected and contagious when I saw them? Even though they weren't maybe tested positive or maybe didn't have their symptoms then. Well, two things. Again, CDC says that if you followed the guidelines, you should be protected. But in the event that you didn't, or there's any inconsistencies in doing that, you should be performing self-monitoring with delegated supervision. What is that? Well, as we referred to, it's taking your body temp twice a day. It's monitoring for your symptoms before you head to the office, when you leave the office, certainly. And so you're monitoring, self-monitoring with delegated supervision. Now, the delegated supervision all boils down to when you have staff that are in that low risk category, that everybody in the clinic is doing that, getting their body temps done twice a day, screening again twice a day, and then they're reporting that to the owner doctor or to whoever's in charge in the clinic facility. And so it's self-monitoring, they're self-monitoring, but it's a delegated supervision to the doctor. And of course, healthcare personnel not using all recommended PPE, who have only brief interactions with the patient, regardless of whether the patient was wearing a face mask, are considered low risk. And of course, this is the brief interaction description, though. It's brief conversations at the front desk, briefly entering a patient room but not having direct contact with the patient, or the patient's secretions, excretions, entering the patient room immediately after the patient was discharged. So those are considered brief interactions by the CDC. And if you were not wearing PPE and you were involved in that type of brief interaction, that you would be considered to be in the low risk category. All right, so we covered no risk, right? And we covered low risk. So what about medium and high risk exposure? Now this is where things get much more involved. And as we talk about medium risk and high risk exposure, we're talking about direct contact with patients who have COVID-19. All right, so medium risk exposure, healthcare personnel who had prolonged close contact with patients with COVID-19, all right, who were wearing a face mask, while healthcare personnel nose and mouth were exposed to material potentially infectious with the virus causing COVID-19. So in this particular case, if you're treating a COVID-19 patient and that patient is wearing a face mask, but you were not, then you would be in the medium risk exposure category. All right, let me say that again. So for those healthcare personnel that have close contact with patients with COVID-19, and if the COVID-19 patient was wearing a face mask, but you were not wearing a face mask, then you are considered to be medium risk exposure. All right, so what do we do then? Well, medium risk exposure, if that is the case, you would be excluded from work for 14 days after the last exposure. So there is a work restriction. And that would be because of prolonged contact with a COVID-19 patient, and that patient was wearing a face mask, but you were not. Now, if you were wearing a face mask and that COVID-19 patient was wearing a face mask, then you would be considered to be in the low exposure, low risk exposure category, and there would not be any work restrictions. However, you would be self-monitoring with delegated supervision. All right. And then what about high risk exposures? What is that all about? Well, that's healthcare personnel who have had prolonged close contact with patients with COVID-19 who were not wearing a face mask while the healthcare personnel nose and mouth were exposed. Okay, so that means that neither the COVID patient or the healthcare personnel were wearing face masks. That puts you into a high risk exposure. And of course, again, high risk exposure, excluding from work for 14 days after last exposure, just like the medium risk exposure. And so, what are the recommendations for monitoring based on COVID-19 exposure? Well, the healthcare personnel in any of the risk exposure categories who develop signs and symptoms compatible with COVID-19, again, must establish your established point of contact within your clinic, within your office. If you've got staff that begin developing signs and symptoms, they're going to be contacting you, the owner doctor, and then you will be contacting the public health authorities or whoever that established point of contact in your clinic is to do that, and then making sure that there is an immediate referral for medical evaluation for that staff person. And of course, high and medium risk exposure categories, healthcare personnel in these categories need to undergo active monitoring. And of course, that active monitoring, as we'll talk about in a minute, is conducted by the public health authority. And you'll be restricted from work in any healthcare setting until 14 days after your last exposure. And then if you do develop symptoms, again, I know I sound like a broken record, but the CDC is a broken record in this area. It's all about identifying those symptoms and acting upon them, like what we have talked about. The question, this has been brought up, should I work if I've been exposed to a patient with COVID-19? Right? Well, considering everything that we've talked about, first and foremost, again, what risk category are you in? And being able to determine that, was your COVID-19 patient wearing a mask? Were you wearing a mask? All of that. But then, secondly, the CDC has put this guidance out because of the shortage of healthcare workers. They've been lenient in some of these areas. And so, first of all, facilities, what the CDC says, should consider allowing an asymptomatic healthcare personnel who have had an exposure to a COVID-19 patient to continue to work after options to improve staffing have been exhausted. So if they can't find other staffing options, like, okay, you can let somebody who is asymptomatic that has had exposure go ahead and work, but they need to still report their temperature and absence of symptoms each day prior to starting work. That exposed healthcare personnel must wear a face mask while at work for 14 days after the exposure event, if there's a sufficient supply of face masks. And then if the healthcare personnel develop even mild symptoms consistent with COVID-19, that they must cease patient care activities, and of course follow up with further medical evaluation. And so the CDC, in light of what's going on, considers what is the impact of that healthcare provider not being in their job And if they are asymptomatic, they're saying, okay, we're going to take kind of a wait and see approach, but you're still going to be self-monitoring, right? And you're still going to be watching very closely if you have symptoms, and you would be needing to wear a face mask. And it'd be that time period of that 14 days would be an important time period to understand. So we've touched a lot even already on monitoring, but let's go ahead and move forward now and talk about the different types of monitoring. And of course, self-observation means that people just need to remain cognizant or alert and be aware of those symptoms: fever, cough, disability, difficulty breathing. Self-monitoring, you take it a step up from that, and that's when you're taking your temperature a couple times a day. Of course, still being aware of the symptoms. And those are things that people can do for themselves. And the self-monitoring, when you're doing your body temp, checking for fever, and as an individual person, those are things that we can and should be doing for ourselves. Now, as we talked about the self-monitoring with delegated supervision, we mentioned that a number of different times in these risk categories. And of course, the healthcare providers, the self-monitoring is going to involve exactly what we talked about, making sure that there's body temps done twice a day and monitoring their symptoms for screening. And that's done within the healthcare facility. That's done, and you appoint somebody within the practice that is going to be the main contact person that is supervising that. And then all the staff people, again, just like clockwork, when you arrive at work or when you leave work, that screening and that body temp is done before and after, and during the day if symptoms arise, obviously, and then taking action on that. Now, the self-monitoring with public health supervision and active monitoring is what happens when you report a person that may be potentially infected, and so and they would be regarded as people under investigation. And so, as you think about that, the main strategy here that we want to implement within our practices would be the self-monitoring with delegated supervision. And again, on days staff and doctor are scheduled to work, you'd consider measuring the temperature, assessing symptoms twice a day, before work, end of work shift, and of course making sure that is reported to the main contact person within the practice, and then to be able to move forward with that in the event that you would need to report to a public health authority. Now, if you report patients and or staff, healthcare personnel to a public health authority because of symptoms, positive screenings, and the like, that they begin then their self-monitoring process with public health supervision, and they assume the responsibility for oversight of self-monitoring for certain groups of people. And so they also then begin active monitoring, whereby they'll establish a regular communication, sometimes daily, with potentially exposed people. So lastly, as we think about this whole piece, and let's say that we have staff that have been infected with COVID-19, needed to take a couple of weeks off, how do we know when it's time for them to come back? Well, the CDC again has laid out some guidelines for return to work, and what they recommend is actually the use of one of these two strategies, if you will. They have a test-based strategy, and so the staff person would be excluded from work until the resolution of fever without use of fever-reducing meds and improvement in the respiratory symptoms and negative results, okay, of testing. Or you can take the non-test based strategy, and they would be excluded from work until at least 3 days, 72 hours have passed since recovery, defined as resolution of fever without the use of fever-reducing meds, improvement in respiratory symptoms, and at least 7 days have passed since symptoms first appeared. And so one of those two strategies are what will help you know if you should allow either yourself or other healthcare personnel in your practice to be able to return back into the healthcare setting. And then when they do return, or when you do return back into your practice, wearing a face mask at all times is important until all the symptoms are completely resolved, or until 14 days after illness onset, whichever is longer. You need to be restricted from contact with severely immunocompromised patients until 14 days after the illness onset. Need to adhere to hand hygiene. All of those things that we talked about in the past, personal protective equipment and the like, it's still good to continue with that type of routine procedures. And then self-monitor for symptoms and seek reevaluation from your primary care provider if respiratory symptoms recur or worsen. And then if it's a staff person that this is happening to, that they need to make sure they talk to you, the doctor, or that key person that is the main point of contact within the practice that they're delegated to report their self-monitoring to. And then, of course, it's very important, again, healthcare personnel, that we adhere to all recommended infection prevention and control practices. And the CDC goes on to say that proper adherence to currently recommended infection control practices, including all recommended PPE, should protect healthcare personnel from having prolonged it should protect healthcare personnel who do have prolonged close contact with patients infected with COVID-19. And again, if we're not using them appropriately, or if we have some inconsistency, that we perform our self-monitoring with delegated supervision, and because we would be within that low risk exposure category. And of course, community or travel associated exposures, important to monitor that as well. We've gone down that road, and that if there's anybody within the staff that has had those types of exposures, that they make that known, and the CDC has recommendations as for how to approach the travel associated exposures. And then just some additional considerations and recommendations that the CDC makes. You should shift emphasis to more routine practices, which include asking healthcare personnel to report recognized exposures, regular monitoring themselves for fever and symptoms, as we've talked about. Don't report to work when you're ill. Developing that plan to screen symptoms and evaluate your people, and implementing that self-monitoring with delegated supervision. Again, very key within the practice. And then the CDC has put this out: when no face masks are available, which we're running into, right? What are the things that you need to do to be able to counter that? Well, first of all, excluding healthcare personnel at higher risk for severe illness from COVID-19 contact with known or suspected COVID-19 patients would be the top thing. If they don't have anything to protect themselves, we certainly want to take them out of the equation. And then, of course, considering also those who have already had COVID-19 but maybe have recovered from COVID-19, they may be people that are already immune, that would be able to step in and take care of people and maybe not need the face mask. Making sure that we have some exhaust portable fan devices to help circulate, and then the use of homemade masks. And so these are not ideal situations, as you know, but if you go right to the link and read more about the CDC's response and what do we do if, it'll give you a good indication as to what they expect from us in this particular situation. And then, of course, documenting your COVID-19 experience in your practice. Document your patient screening that you're doing over the phone, and when they arrive, when you refer patients who screen positive to their primary care provider and to your public health authority, and charting the patient that the patient denies symptoms if they did come in, that they denied symptoms related to COVID-19 and when you treated them. Document your infection control procedures, what you're doing within your practice in terms of disinfecting and use of PPE, and how you have your patients come in and how you're triaging them and screening them, and of course, again, monitoring your doctors and staff and assigning risk exposure. Very important. That's what we've learned today, right? Is to be able to understand what risk category are we in, what do we need to do to keep ourselves out of that risk category, and then following work restriction and return to work guidelines is very important. This particular link will bring you to this page in the CDC, information for healthcare professionals, and there's so many links on this page, but it brings you into a lot of key areas that we've covered now today that will help you get a good firm grasp on how to move forward. And then, as always, stay informed. We have our link, we have our resource page. Many organizations have resource pages available, and so use the ones that you feel are the most advantage, give you the best advantage to helping understand what's going on and how to react and be able to do deep dives into becoming more knowledgeable. That's the thing. What we can do is we can help pull things together and give you a running start. It's important to understand that you're responsible to have that knowledge base and to be able to implement what you need to implement. And of course, we are providing different releases, so you'll see them come through. And we just ask you to join us again. This is a conversation that is not going to go away for a bit. And we have assembled a very strong lineup of resources. And so we hope that you'll join us again, contribute to the conversation, ask the key questions, and that's what these webinars are really all about, is to generate questions, generate comments, and hopefully we can all begin to become much more knowledgeable as we move forward in this public health crisis. And again, just keep in mind, you're not alone. Knowledge replaces fear, and the more knowledgeable that we become in this area of infection control and understanding what we need to be doing to create and maintain a clean practice environment, and what we need to be doing to screen our patients and clinical assessment, and understanding how we can help them better during this stage, and what's our public health responsibility when it comes down to reporting, and how do we take better care of ourselves and our staff, and risk categorization like we talked about. All of these things just seem like a lot to be on our plate, but as we move ahead, the more that we read about it, understand about it, talk about it, will get us to that point rather quickly where we will be operating as the healthcare facility that we need to be at this point in time. So with that, I want to thank you again for listening, and looking forward to more conversations with you. Take care.
Well, thank y'all. Y'all have submitted a lot of questions, and a big shout out to Ashley for texting me and saying, please turn your mic off, since y'all heard me typing away. So I'm sorry, guys. But let's get down to all of these questions. The first one is, I'm not against wearing face masks if they are beneficial. Is there anything that shows that they have any value?
You know what? Now probably isn't the time to question that. I think from a excuse me, from a pragmatic standpoint, and because of the direction that the CDC has provided us, and just think about what is the mode of transmission here. Well, it's secretions and excretions, respiratory, right? And so we need to block it. And the best way to block it that we know today is to use face masks. So I think at this stage of the game, rather than questioning, gee, is this a value or not a value? Let's just bring some pragmatism and really maybe some clinical common sense. And then let's debate that later as to what the studies may say or not say. But right now, it's so important, Christy, and I was watching the questions come through. And this may take care of some of them. We can probably get ahead of it a little bit. I saw a lot of questions about face masks. What do I do? Should I be wearing them or what? And the answer is yes, you should be wearing them now. I would highly recommend, especially as we go into this next 2 to 3 weeks, with the peak of the bell curve, coming up. I mean, we're seeing almost a straight vertical climb, if you will, of cases reported. And the thing is that now's not the time to take chances with patients and with yourself and with your staff. And so the answer is yes, please do that. Secondly, we've been talking about screening patients for over 2 weeks, 2.5 weeks, as a matter of fact. And when we talk about screening patients, we're screening their symptoms. If they have 1 or 2 of those symptoms, fever, cough, difficulty breathing, yes, those are symptoms that could be COVID related. And so, yes, they need to see their primary care provider. Better to be safe than sorry. If they get a clear bill of health from them, then great, let's go for it. But in the event that you do screen somebody positive, keep in mind that our responsibility, or maybe we have a patient that has come in and they weren't COVID related, but then afterwards we learned they were, we need to just report that to the public health authority. Let them know that we screened somebody positive. The public health authority, whether it's your local or state, and we provided those links for you to become familiar with them, they're the ones that take it from there, and take your cue from them as well. I mean, if they give you some advice, or if they ask you to do something, let's do everything we can to help that. And that's one of the key strategies, as we've outlined already in regards to this whole crisis, is, what do we do to keep our facility clean? What do we do for patient care? And then, of course, what's our public health responsibility? I saw a question about, again, face mask question here. And of course, that last slide that I directed a link to the CDC, there was a question about, can I clean my face mask? And I would really recommend you go to the manufacturer's website and maybe do a little bit of digging on that. I don't have an answer for you on that, but that's where I would recommend that you seek that advice. And especially at a time and a shortage that we have, certainly doing our best to try to clean it makes sense to me. But again, go to the manufacturer for that particular advice. Christy, I'll go ahead.
Let's see. Let me look on here again. A lot of y'all are asking where to buy the face mask, and several people have said to try Amazon Business, not regular Amazon. So check that out. One of the questions was, can we use surgical masks instead of N95 masks?
Right now, even homemade masks, if you don't have any masks, make one or use whatever you can get your hands on.
Perfect.
It's better than nothing, right?
Should they be wearing masks and gloves and face shields in practice right now?
Okay, so the face shield, in terms of like the eye protection, if there's a chance that you're going to be involved in something where there's like aerosol spraying or that type of thing, like they would more in like an ER setting, that's one thing. And if something's going to like splash on you, but with regular patient care that we typically provide, and we have that close contact with adjusting patients and talking to them and some of that, a face mask and gloves, I believe are plenty, are good. But again, take that under your own clinical judgment as well. All right. And if you want to goggle up, goggle up. If you feel like there's potential that you could get something in your eyes, then absolutely do it. I mean, use your discretion on that.
Okay. So if you treat a patient and neither of you have a mask and they leave and call the next day or two and say they tested positive, is that an automatic 14-day quarantine?
So that's a good question, because if they were asymptomatic at the time that you saw them, and then later in the day or whatever it happens that they had that, what I would recommend that you do, the CDC says that if they were asymptomatic at the time, that you're okay to work, but you need to take precautions. Make sure you wear a face mask, that you do your self-monitoring. And remember, we talked about that as well towards the end, that everybody right now at this stage, I'd say moving forward over the next month, make sure that you self-monitor with that delegated supervision, meaning that you check everybody, every staff, every doctor's body temp, screen them when they come to work and when they leave work. And if there's any change during the day, that gets monitored. But definitely go through a self-monitoring process. If you treat a COVID patient, okay, then that would put you into that medium risk category now, all right? But since that patient was asymptomatic at the time, that's what the CDC is telling us. So again, make sure that you wear your face mask, have that source control on yourself, and then monitor your symptoms. And again, go into that self-monitoring with delegated supervision for your staff as well.
Well, and then somebody just asked, so if we follow these guidelines, we should not be seeing anyone that is known to have COVID-19, correct? That
would be correct. I mean, certainly we're trying to screen those people out, get them to their for medical treatment, medical evaluation. And unless you find yourself in a situation where you feel the need to maybe go to a patient's house and treat them, and if you find yourself in that situation where you feel clinically you need to do that, then by all means, that patient needs to have a face mask. You need to have a face mask with PPE, and then you keep yourself in that low risk category. And that's why I wanted to cover that today with COVID patients, so that we can, see what this is like, and how the CDC has laid out, these low, medium, high risk. And then it gives us a little bit better understanding as to maybe where we're at in the situations that we find ourselves in. But to answer that question, yeah, you hopefully will not find yourself in a situation where you're treating a COVID patient. But if you do, for your reasoning to do that and put yourself in that situation, then make sure you're protected to keep yourself in that low risk category.
Do you have to inform other patients that a positive patient has been seen in the office?
Okay, and we covered this, and I'm going to cover it again. The answer is no. And so your responsibility to report is to your local or state public health authority, right? And then that conversation you have with them, then you take whatever direction that they provide you at that particular point in time. But our responsibility from a public health perspective is that when we screen somebody and they're positive, and or we come into those situations, we call them because they need to be a person under investigation, right? A PUI, and then they take it from that point and they do their self-monitoring, active monitoring, depending on what level of exposure and potential, if they've been tested or not, and how that turned out for them. So if we do a handoff, if you will, but definitely keep in mind that you're going to be working with those public health authorities along those lines.
What if a patient has just a cough? Is that enough to report them? How many clinical symptoms need to be present to be worried? A cough could just be related to allergies.
And again, this is no time to guess, right? It just isn't. So fever, cough, shortness of breath. Fever, like 98% of the time, it is COVID related. Now, today, when they happen right now, 98% of the time, fever is a part of that symptom complex. Over 85% of the time, cough is. All right. So now is not the time to guess. If they have a cough, definitely send them for medical care. You can give your public health authority a call and say, hey, I had so-and-so, they had a cough, and then hand it off. Let them know about it. That's our job to do.
What's the definition of a fever? 100 or 100.4? How many readings is necessary to conclude a high temp?
Yeah, and we've seen 100, we've seen 100.4, anything over 100. Okay, anything over 100. And I believe there was also a question too, Christy, about taking vitals, and what we've recommended is that when we do our clinical screening as clinicians, it's a part of how we take vitals. And so what we've recommended is that, yes, go ahead, not only with body temp on every patient, we've been saying this for 2.5 weeks, but also do their blood pressure, pulse, respiration. That's going to give you a pretty good indication. And at the same time, talk to them about their travel, and then their symptoms, those types of things. And so that's a great time just to do an evaluation on them. It's going to take about 2 minutes as you get fluent at doing that and at the ease of doing it. And you're going to have a lot of good information from a clinical perspective. And we'll have done your clinical job at this point in time. And I told you what I thought close contact was in the chiropractic practice, right? I mean, we've got doctors, we have providers, we have front desk staff, we have CAs that may work with patients directly in modalities and rehab and all of that. All of you folks need to be wearing face masks. In my opinion, based on what I know, that's what I would recommend at this stage of the game.
Okay. If a patient calls and says that they have tested positive for COVID-19, are we required to call the local health department or just monitor our employees and our own symptoms?
Yes, and so if they have been tested as being positive with COVID, then they more than likely already are reported by the doctor that tested them, okay? So make sure you ask that question. And if you're ever in doubt, like, gee, I don't know if they did or if they think they have it or whatever, you can always go ahead and call, because and let the local or state authorities know. And they probably already have them as a person under investigation, and then that's fine. And so if you're ever in doubt, again, this is no time to guess. We're at that stage within this crisis, and it really have been probably over the last week or two, and will be more so over the next 2 to 4 weeks. Whether it's hit home to you or not, where you're at, we have to all buckle down and understand that we have processes here that need to be followed. And I would go over and above and not second guess.
Let's see. Once we report them to the health department, do they call and harass the patient? That's a good question.
They do active monitoring. So if you call that harassing, I don't know that that would be harassing, because if they are active, they're going to follow up with them to make sure that they're screened, not only screened, but tested as well. And so, this is a public health issue, right? It's a crisis, and that's just the way that it rolls.
Okay, so we're still getting a lot of questions about the mask. So bottom line is you need to wear a mask or any kind of mask if you cannot find the N95 masks, correct, Dr. Munsterman?
I would wear whatever you can get your hands on, frankly. And there's health systems, medical health systems that have asked people to make masks for them, and so having something rather than nothing is really the key here. But do the best that you can.
Okay, let's see. I'm going to ask one more question. So I'm scrolling through these 500 that are still in here real quick. Oh, y'all are making this thing spin faster than the wheel of fortune. Okay. What is considered an acute patient if we're only treating those in practice right now?
Yeah, well, acute pain is actually categorized as that first month after an injury. And of course, subacute pain is anywhere from 4 weeks to 8 weeks, and then chronic begins after 12 weeks. And so if you're basing it based on the pain guidelines that are out there, that's what you can be thinking about. But then to back away from that, sharp, constant pain, I mean, if it's debilitating, that's certainly a consideration. That tells us that there's active inflammatory response going on from an injury. That's the thing. I mean, injuries have not maybe necessarily been put on hold here. And so we know that there's some situations that need to be addressed that are neuromusculoskeletal, and we can help take the load off of our medical colleagues so they can focus on these COVID patients. And so that's one of the reasons why we're deemed as essential as clinicians right now. And so anyway, but yeah, acute would be those constant, intense pain situations. Range of motion obviously is diminished considerably. You may have positive orthopedic findings. I mean, we're talking about those cases, I guess, in general.
Okay, guys. So here's what I did is I copied all of the rest of y'all's questions and I put them in a spreadsheet. I'm going to send those out to y'all, and I'll highlight in the notes where Dr. Munsterman answered that question. If there's any question that maybe there's a little more information needed, I'm going to get that from him and I will send that to you. Mm-hmm. This was recorded for all those of y'all who jumped in late, and the link to the recording will be out in an hour. And for some reason you could not download the handouts under the files, go ahead and send me an email and I will send them directly to you. I want to make sure that you have those. And I want to thank y'all for being here today. Just to remind y'all, we have another webinar, same time, same place tomorrow. With Dr. Foxworth, and we also have Don Rasmussen, who is going to be back to talk more about some of the updates with all of the SBA loans. We also have Attorney Erica Ribb, who's coming back, and she's going to be talking about unemployment benefits for self-employed people. So make sure you go to our website, ChiroHealthUSA.com, and register for that webinar, because you don't want to miss it. Even if the time's not good, remember, if you register for it, we will send you the link to the recording. So thanks, guys, for being here today, and we will see you tomorrow.
Yep. Thanks, everybody.
Bye.
Hang in there.